panel of experts. We're expecting Dr. Owen Ngalamika, who will be joining us momentarily. Then we equally have Dr. Aubrey Makai, Dr. Andrew Zulu, Dr. Sombo Fwoloshi, as well as Teddy Kajimotu, equally joining us. And I will be encouraged to make use of the chat so that if there action is being done, you can post your question session for any discussion and question to one.
Is it just me or the doctor's dropped out?
I guess he has dropped out, because I can't get anything.
Oh,
Okay.
apologies for that. Dr. Malan, you can go ahead and make the presentation. Thank you.
Okay.
Hi, Dr. Malan. I've given you control of the slides, so you may kindly control the slides from your end.
Oh, okay. All right. Thanks. Thanks. Good afternoon, everyone. We'll dive into today's topic on common dermatological conditions that we see in clients with advanced HIV disease. I should make mention that some of these conditions, we can still find them even in those who are HIV negative, except that they are common and they may be aggressive in HIV, in patients living with HIV. My name is Malan. I'm based in Livingstone with Mlungushi University and also the Livingstone University Teaching Hospital. But I do visit different places from time to time, Osaka and Dora and all. Yeah. So today's learning objectives, one, to discuss the common dermatological manifestations associated with advanced HIV disease. Secondly, to highlight the clinical presentation of this dermatological condition in this key population. The third is to discuss the diagnostic approach to dermatological conditions, okay? And finally, to outline the management of these common dermatological conditions. So when we dive into the various disease conditions, we'll be talking about, we'll be exhausting the diagnostic and the management part and the clinical presentation so that you get to meet all these things. So I know most of you are working, you've seen most of these conditions. We have a poll question which we can try and attempt. Which of the following skin condition is the most common indicator of HIV disease, HIV/AIDS? We can try that out. You can see some are saying A. So it could be more than one answer correct there. C, A. Okay. So the keyword here is indicator of advanced HIV disease. Okay, we go to the next question. What is the most likely cause of widespread chronic itchy skin rashes in patients with untreated advanced HIV disease? The clock starts now. Bambula, hivi karibu viziba hapo hivi vyamuchitira as we are not from the technological era.
Guys, so I have launched the polls. Are you able to see them?
I'm able to see.
Okay.
That's okay. That's fine.
Yeah, so usually we give them about a minute, or depending on majority voting, then we can
Oh, yeah.
close and then share the results. So with your guidance, you can tell me when to stop sharing, and then I can share with share the results.
Okay.
Yeah, so I'll wait your guidance to stop sharing the poll.
Okay. All right. We're at 76. So maybe when you do 80%, we can
Okay, so I've stopped sharing the poll.
yeah. So we can go to the next question, right?
Yes, please. But maybe you can just show the audience how they voted. Then we go to the next poll. So I've shared the results.
How they voted.
Yeah,
So
so this is how they voted.
Yeah, so the majority, about 51%, got it right. Uritic papular eruption. That's the correct answer. Okay. Yeah, episodes that doesn't really cause widespread chronic itchy skin. Okay. Yeah. So scabies usually it's localized in the groins, finger webs, and whatnot. Drug reaction, yes, it may be generalized, but it's not. If someone has got untreated HIV disease, they may not ingest. There may be no history of drug ingestion and whatnot, so it's not right. So the correct answer is B. Okay, so we can go to the next. Third question. A patient with HIV presents with multiple painful grouped vesicles on an erythematous base following a dermatomal pattern. What is the most likely diagnosis? So from the way people are voting, it shows that there is need for us to have this presentation. Yeah. So it's I think it's important that we have this presentation. So we can see that some voted on impetigo.
Can you give us some information? Yes, and we create a WhatsApp.
Someone's mic is on, others voted on Kaposi sarcoma, but I think the majority, the correct answer is epizoster. It's grouped painful vesicles. Keyword there is dermatomal pattern. It always follows the dermatome. So the correct answer is B. Okay. Yeah. So it has just shown us that we actually need this this chart. So a background to common dermatological manifestation is that skin condition amongst the earliest signs of advanced HIV disease. Okay, they often indicate immune suppression, and others they indicate opportunistic infection. Okay, we should realize that these skin manifestation can be caused by either infectious things or non-infectious, of which we have malignancies, inflammatory disorders, and drug reactions. Okay. So we can safely classify them, okay, for easier understanding. We can classify them into at least 4 or so groups. Okay, infectious conditions, which you have the viral conditions like epizoster, molluscum, Kaposi sarcoma. Yes, it's a malignancy, but the HSV infection 8. Okay, bacterial, we have the staph infection. This even HIV people may still get this. The fungal, parasitic infections. Okay, inflammatory conditions, we have these seborrheic dermatitis, psoriasis, eosinophilic folliculitis. Okay, then when you move to the HIV related malignancies, which Kaposi sarcoma usually adopts, and you can have other malignancies that may pop up due to immune suppression, but top is KS. Then you have the drug reactions. You know that these individuals are usually on cocktail of drugs. Okay. So there's a list of 10 common skin conditions to know in people living with HIV, which was a study done by Data in Health Africa Incorporated. Okay. So we'll diving into these disease conditions with put them in different batches. So the infectious cohort of diseases that are common in people with HIV, number 1 is epizoster. So it's caused by varicella zoster, and it hails from a primary infection which results in chicken pox. Okay, so it's more severe in the HIV population, and results in a viral latence where this bug hides in the nerves. Okay, and when there is immune suppression, there is reactivation of the latent varicella zoster virus, which leads to the epizoster with extensive dermatomal lesions, okay, as we can see in the picture. So the clinical picture, okay, you have these vesicles on an erythematous base, okay, affecting a single multiple dermatome. So you may find that it can follow a single dermatomal region or other dermatomes, okay. And these lesions are usually painful, and people will tell you that they have pain inside. So at first, it may just start as pain before you actually see the blisters. And the local name, it's usually referred to as mulirowaleza. So most clients will actually come and tell you that they've suffered from mulirowaleza. So the most important thing is that you confirm and that it's the one, and you treat as appropriate. So diagnosis, usually clinical, okay. Usually doesn't cross the dermatome. If you can see on the face of this gentleman, this is the post-herpetic scar that they have. Just affects half side of the body and all. So treatment, oral cyclophosphamide, 800 high dose, 800 milligrams, 5 times daily for a week plus, depending on how the patient is responding. And if the symptoms, the lesion seems to persist, you can do IV cyclophosphamide. And those that are resistant to cyclophosphamide, you may give oscanate, okay, the drug of choice. So for pain management, gabapentin or pregabalin it does well, and in resource deficient areas, even carbamazepine. Complication of this condition, most people have this post-herpetic neuralgia, okay, and scarring, okay. So others, if it affects the eye, you may have corneal scarring and whatnot. So if it involves the face, you may need to involve the ophthalmologist to make sure that you prevent any eye damage, okay. Second one is molluscum contagiosum. It's caused by epoxy virus. It's a common pediatric condition, except that in adults, it's usually sexually transmitted and may affect the genital area. So how it spreads is that if you look at the picture, these dome-shaped lesions, when you squeeze it, they are painless, but when you squeeze it, produces a caseous whitish substance, which is the infective thing. So once you squeeze it and you rub it on, it seeds the virus, okay. Clinical features, dome-shaped papules with a central umbilication. Okay, some people may actually think that they are razor bumps, and that's the commonest presentation that I've had with most of my patients. They'll say, no, I have these razor bumps which seem to not to be going, and they're increasing. Okay, treatment. You could use cryotherapy, where you use liquid nitrogen, or you could use could cauterize them, okay. The use of imiquimod works, or even just curettage, okay. And in those who are ART may help improve the immune system, okay. So even in children, you can advise that it's a self-limiting condition. So if the immune system is intact, without doing anything, these lesions can disappear. But in the HIV population, they're usually aggressive and all. So we had done a letter to the editor in the Medical Journal of Zambia where we looked at other methods that you could use to form of cauterization, but using just the local available materials. You can spend time to just look at that paper. This one, molluscum contagiosum therapeutic challenge. Okay. So the other condition, these are fungal infections. They are very common in advanced HIV, and a long time when we're interns, you find that someone has got maybe pneumonia. You put them on the IV antibiotics, and temperatures are not going down. You just peep in the mouth, you find they have thrush. So it's something that can be one of the early manifestation of advanced HIV. So candidiasis is also referred to as oral thrush, okay, caused by yeast called candida. Okay, it's characterized by these white patches that you see on the tongue and on the other parts of the mouth. Okay, this can also affect other parts of the body. Okay, even the vagina, and also the symptoms usually for vaginal burning sensation, itchiness, curdy vaginal thick discharge. Okay, yeah, and in severe cases, you may actually see them on the skin, okay, under the fingernails, toes, the rectum, and the anal region. So, okay, treatment. So for diagnosis, really is clinical. Do examination, you notice this. Treatment is antifungals, proconazole, oral, IV, depending how the patient presents. Okay, conazole, terbinafine, and other antifungals can be used. Okay, depending what's available in your place. Okay, scabies. Okay, so individuals with weakened immune system. Okay, they are usually at high risk of developing crusted or the Norwegian scabies. Okay, this advanced form of the infection can involve a large number of mice. Okay, leading to dry, scaly patches on the skin, like as seen in the picture. Okay. The Norwegian scabies, okay, are highly contagious and can lead to secondary bacterial infection, okay, posing a serious threat to life. Okay, and must note that itching may not be a prominent feature in these cases of crusted scabies, so it's something that you may need to have at the back of your mind, that it's possible that these individuals may actually present with severe form of scabies. And treatment option, you have the topical medication like permethrin 5% or 2%, depending on the age, and benzoyl lotion can also be used. Other literatures also recommend the use of ivermectin, either the IV or the oral, though it's been phased out for human use, but I think in other settings they can still use ivermectin. What's the HPV infection? Okay, so what's usually these individuals with who have HIV, advanced HIV, may present with the flat warts, okay, which we refer to as verruca planus, okay. Can also present with common warts, verruca vulgaris, or genital warts, which is condyloma acuminata, okay, and they are all caused by human papillomavirus, and they are more extensive in the immune suppressed individuals, okay, and extensive flat warts are common in individuals with congenital HIV infection, okay, and what I have noticed, even if you get to improve the immune system of these individuals, the flat warts they may persist for a longer duration. I think we'll see if we could find a permanent solution for these individuals, and we'll share with the team. So clinical features, I think, for common warts, they're usually found on the limbs, okay, legs, and these are firm nodular lesions, whereas the condyloma acuminata, you may find them mostly genital areas, okay, yeah, and maybe filiform or cauliflower-like lesions, okay. The flat warts, as mentioned, they are usually flat, whitish lesion and all, okay. So for treatment, I think what has been the practice for me is cauterization cryotherapy. Works well, and in extensive cases, you could use imiquimod cream. Okay, you apply for twice, 3 times in a week for 6 to 8 weeks. That's shown a lot of improvement. Fluorouracil, it's some literature have recommended fluorouracil cream for the flat warts. High concentration of salicylic acid, 15 to 25%, depending how the patient tolerates that, you could use that. Podophyllene, pent, and silver nitrate have also been used. They also work. I think it's something that it's common practice. So herpes simplex, usually caused by type 1 and or type 2. Type 2 is usually below the belt, but these days we know how people are doing sex. So you can find type 2 on the lips, okay, the mouth, and vice versa, just like that. So, yeah. And the common sites include the lips and the genitalia, okay. Clinical features, they present with multiple painful grouped vesicles on a erythematous base, but most of the times by the time patients present, they'll present as erosious, painful ulcers, okay? Because you may find that the vesicles would have ruptured due to pressure or friction, okay? And this is something that you need to be clear and tell your patient that once they have herpes simplex, there is no cure, though we could use suppressive treatment or options to just help suppress and for symptomatic therapy. So you can put them on a cyclova or give them a bit of painkillers and all to just help with the pain. So cyclova cream and anti-inflammatory creams to just help with the symptomatic treatment. However, these things, they tend to recur, okay. So other infections like the fungal infections, we have tinea infection. So it affects the head, usually tinea capitis, the body, tinea corporis, okay, and the feet, tinea pedis, the intergenous areas, tinea cruris. When it affects the nails, black nails like this, tinea onychomycosis. Okay, and these individuals also may present with pityriasis vesicola or tinea vesicola or the combat rash. Okay, which local term call it bangwash. Okay, or ulota, depending on where you come from. So usually diagnosis for experienced individuals, clinical, or you can do KOH, potassium hydroxide scrapings. You do KOH scrapings on these things, then you see the meat or appearance, and then you offer the treatment. So fungal and oral ones you could use terbinafine, isoflavin, and these other antifungals do work. So combination of both topical and oral is usually good for these individuals. Okay. So we dive into the second group of conditions that are common in the HIV community, advanced indicators of advanced HIV, inflammatory and immune-mediated conditions. So first, it's psoriasis. Okay, it's a condition that even those who are HIV negative have, but it's more common and more severe in HIV-infected individuals, and it's characterized by increased epidermal cell turnover. Okay, clinical features is that they may present with erythematous red raised, okay, or people of color silvery scaly white scales, okay, as seen in the picture below. Okay, and it may affect the scalp, extensor surfaces, and nails, and may present as arthritis in some individuals. Okay, psoriatic nail or psoriatic arthritis. So, in some patients, the first clinical presentation is that they will just tell you that I have a lot of dandruff. Okay, so it may be the early signs of psoriasis and all. Okay, diagnosis usually clinical, but if you're in limbo, you can do biopsy, okay, of the lesion. Okay, take it for histopathology. They will tell you that there are mono abscesses and whatnot. But also, just through a physical examination, one can actually tell that this is psoriasis. Okay, where you have Kobner phenomena, where they injure themselves, then they develop those lesions and all. So treatment, we have a range depending on how severe the lesions are. So from topical to systemic medication. So topical steroids in the initial phases or stages, you could use potent steroids. Okay, quarter ointments and shampoos can be used. Topical vitamin D derivative analog creams can be used. Okay. What I have been using for most of my clients is oral methotrexate, depending on how severe, between 5 milligrams to as high as 15, 20 milligrams once weekly for some months, and you monitor other things. So it has worked. But other immune suppressive drugs, cyclosporine can be used, tacrolimus, and though they are just expensive. Okay. Eczema. So atopic dermatitis. So eczema is common. It's a common disease that you see in any other individual, even those who are HIV negative, but in those with may present as a a severe form in HIV to learn, okay, and act aggressively and treat. So clinical features in acute stage, it's characterized by itchy, okay, oozing erythematous patches in the flexure regions, neck, okay, and in chronic cases, you may see that they'll have dry and scaly lesions. And you can find those secondary characteristics of chronic itchiness like degenification and all, okay, hyperpigmentation, okay. So it may start in the early months or weeks in children, okay, and may affect the face, especially in children where you have children present like they have slapped cheeks, okay, scaly, fine scales on the cheeks and all, irritable kids, okay, that's the infantile stage. And as they get older, you may find that it will be in flexure areas and all, okay. And in adults, you may find that it affects the hands more, okay. Yeah. So diagnosis, usually it's clinical. You may need to have seen a lot of these cases or just a few, okay, and they'll tell you that they've had this lesion for a long time. And there's also positive history of asthma, okay, or allergies to different kind of food and environmental factors, okay. So treatment, usually cocktail of other things, okay. So from topical steroids and emollients, the creams, the aqueous creams, and topical calcineurin inhibitors like the tacrolimus can be used, and antihistamine, both a systemic and topical, okay. But what has been helpful for me is the combination of steroids. You mix steroids and emollients, the aqueous creams, you put them, you mix together, and they start using it as lotion. Really works well for these individuals. Okay. So pruritic papular eruption. Okay. It's a chronic itchy papular skin disorder which is seen in advanced HIV/AIDS individuals. It's characterized by multiple systemic, symmetrically distributed hyperpigmented or erythematous papules, and it's common in the extensor surfaces, arms, legs, trunk, face, and strongly linked to low CD4, less than 200. Okay. Cause and pathophysiology, the exact cause is unclear, okay, but it's believed to hypersensitivity to environmental factors or allergen and insect bites due to immune dysregulation. Okay, so diagnosis usually is clinical, but if you're in limbo, you may do a biopsy, may show lymphocytic infiltration and eosinophilia. So these are the pictures that you see of these individuals, generalized, okay, itchy rash, okay. Yeah. So in terms of treatment, these are individuals that you may need to initiate on antiretroviral therapy, okay. And it's the most effective long-term treatment. And topical steroids, okay, hydrocortisone, beclomethasone, triamcinolone. You could use that to help reduce the inflammation, and may need to also add some oral antihistamine, the non-sedative one, okay? And try to advise them to avoid triggers, insect bites, excessive exposure to sun and all. So the other condition that we look at, an inflammatory condition, is seborrheic dermatitis, okay? It's more common in HIV patients, okay? But you can also see it in chronic alcoholics, okay? And it's caused by Malassezia fungal species, and clinically these patients will present with yellowish greasy scales on erythematous base. So these are usually seen in the nasolabial folds, the eyebrows, okay, and lateral aspects of the nose, okay, and the mouth. Very itchy, okay, as seen in the picture. So treatment, diagnosis also is clinical, okay, and like psoriasis could be a differential of psoriasis, so they present also with dandruff. So antifungal, topical antifungal creams and shampoos can be used. Okay. Topical steroids like triamcinolone can be used, and the others that you can find. Eosinophilic folliculitis, okay, usually occurs in advanced HIV disease. Its cause is also unknown, characterized by reddish papules, which are about 2.5 millimeters. Okay. In some cases, they may form pustules. Okay. And they're usually centered around the hair follicles, and usually affects the face, trunk, and upper limbs. Unlike the other conditions that we talked about, pruritic, the lesions are also very itchy. Okay, so diagnosis also clinical. Okay, and treatment similar to PPE. Initiate them on ART, topical steroids, and histamine. They may give a mixed picture of scabby mite infestations, so you may need to add even anti-helminths like permethrin cream and all. Okay. So the best deal, the triple action creams are better, those which are a mix of antifungal, anti-inflammatory, and antibiotic creams may be very helpful, okay, these individuals. So the HIV-related malignancies, that's the other thing we look at. We're running out of time. So Kaposi sarcoma, I think it's something that is known, but these days we realize that it's being missed, especially the early stages. So it's a vascular malignancy caused by human herpes type 8 infection. Okay, it affects both HIV and HIV individuals, but in the it's more common in the HIV infected individuals. Okay, and it is an HIV stage 4 disease. Okay, and studies done shows that it affects males more than females. Okay, clinical features, depending on the stage the patient will present with, maybe macules or plaques or nodules. So, yeah. So they may present at brownish, reddish, or purplish macules, patches, or nodules, depending on the stage that you find them. Okay, and the lesions are not itchy or painful. Okay, in severe cases, they may present with lymphedema. Okay, this condition may also affect the internal organs, lungs, type and nodes and all. So diagnosis usually is clinical, but if you are in limbo, you may do histopathology and immunohistostain. Okay, so GTH, there's a KS lab that is running. Okay, they are looking at these lesions. So if you are in the centers within Lusaka or elsewhere, I think you can get in touch with them or refer the patients for their care. Okay. So treatment, ART alone for early stages. Okay. Few lesions, no lymphedema, no visceral involvement. You could actually treat with ART. Okay, but in advanced cases, you may need ART plus chemotherapy. Okay, and usually chemotherapy usually administers for at least over 6 cycles. Okay, so depending on how the patient is faring, can do that. And could use either as a monotherapy. If you're using the second line paclitaxel, you can use it as monotherapy or a combination using the doxorubicin vincristine regimen. Okay. So this is just a slide which shows how KS is used and the drugs that are used. Okay. So you may not find them in most of these other smaller centers, but I think in the general hospitals, I think these drugs can be found. Okay. And you can actually treat this. So 3 combination drug every 3 to 4 weeks, minimum of 6 weeks, but you can go more. Domycin, vincristine every 3 weeks for a minimum of 6 weeks. Paclitaxel was mentioned. Okay. Liposomal doxorubicin also an option for monotherapy if available, but I don't think we have stand to be corrected. And in sick patients, you may use vincristine, okay, as monotherapy weekly, vincristine, okay, follow hemoglobin less than 8 grams per deciliter. So for drug reaction and hypersensitivity reaction category. So in a nutshell, these individuals with who are HIV positive or who have advanced HIV, they tend to have mixed pictures. So most of them, you may find that they will need multiple drugs. So they are usually at a higher risk of developing these drug reactions. Okay. And so the common drug reactions that you may see, okay, usually SJS, Stevenson-Johnson syndrome, toxic epidermonecrolysis, or an overlap of SJS and toxic epidermonecrolysis, or you may have patient present with erythroderma, just basically redness of the whole body. Other drug reactions that you may see is trace or fixed dose eruption, acute eruptive papulosis. Okay. Yeah. So SJS and 10, they are serious and potentially fatal drug reaction, or this erythema multiforme, okay? And it's commonly linked to hypersensitivity reaction to the medication, okay? And like mentioned, individuals with HIV are at increased risk of developing this complication, okay? It's an acute condition, occasionally recurring condition affecting the skin and mucous membrane, okay? Presenting with papular or bullous or necrotic lesions that are caused by specific antigen triggers, so to these drugs that these individuals are taking, okay? So in a few minutes, we just discuss how to approach dermatological conditions. So what is important really is history taking, okay? So in this part, you look at the duration of these lesions, the progression, how these things have progressed, associated symptoms, fever, pain, pruritus, any history of recent infections, medication, okay? Are they on medication, ART and all? Do a proper physical examination. You look at the distribution of morphology, okay, color, the lesion scaling, okay, and try to look for other systemic involvement in the mouth, genital region, whatnot, okay. This usually vital in coming up with what could be the cause or how best to approach this thing. So diagnostic tests, depending on what, thinking that it's infectious, you can do skin scraping, microscopy for fungal elements, or zinc smears for suspected viral infection. Think it's bacterial, either do bacterial cultures for this. When you're in limbo, you do biopsy and all. Serology and PCR for viral infections, and also these are patients that you approach like any other patient, history and take them through those steps. So in conclusion, HIV-related conditions, okay, skin conditions pose a significant challenge to individuals with HIV. Because some of them, they leave permanent scars, and also even if you say you can't tell by looking, but with a skin manifestation, you can actually tell that this person has HIV or the immune suppressed. So every recognition and diagnosis are crucial for timely intervention and for improved outcomes. Okay. Also, continued education, awareness efforts, also funding, okay, for research. Like right now, we have this flat warts. These are patients who are virally suppressed immunologically. The CD4 counts are high, but they still have these lesions. So we need funding to do research on how to best target these lesions and all. Okay, these are essential or effective for management of HIV-associated skin condition in our environment, Zambia and Africa. Okay, so those were just the references that we got this data from. Okay, and those are my contact details in case of drop me an email or message. We can see how we can get to help each other. Okay.
Okay, thank you so much. Thank you so much, Doc, for that detailed and extensive presentation. At this moment, I think since we started with the poll questions, we'll just run through the poll questions to see how knowledge transfer has happened and whether learning has taken place. Then thereafter, we'll only take a few minutes since we are reaching our closing time. So we can just have maybe a few minutes to go through the poll questions, and then thereafter, for anyone who has a question, we can ask. So poll question number 1 has been launched. The question is, which of the following skin conditions is the most common indicator of advanced HIV/AIDS? Single choice answer.
This one has multiple answers.
Oh, okay. So this one has several correct answers.
The other ones, it's single.
All right. So colleagues, let's select our answers. We are currently at 20%. So possibly when we reach 50% of participants, then we can give a chance to Dr. Malan to make a comment on the answers given. So right now we're at 40%. Okay, we have 50% participation. Doc, maybe you can give a comment on the answers that have been given.
So I know they've picked case, stroke case. So the answer is A and D. These are indicator of advanced HIV disease, A and D. Okay. Molluscum, even those who are HIV negative can get seborrheic dermatitis, even other individuals can get, but pruritic papular eruption is almost exclusive to HIV disease, Kaposi's sarcoma. Once you see it, it's an indication of advanced, it's a stage 4, and most people have gotten it right. So A and D. We can do the next
Okay,
question.
so we can move to the next poll question. So this one is, what is the most likely cause of widespread chronic itchy skin rashes in a person with untreated advanced HIV? A, scabies, B, pruritic papular eruption, C, drug reaction, D, epizoster. So we are currently at 25% at least voting chronic itchy skin rashes in advanced HIV. Okay, we can end the poll and share the results. Doc, any comments?
So the correct answer is B. Okay. Epizoster is dermatomal. Drug reactions, usually if an advanced HIV patient is not on any drugs, you may not even see any drug reaction. Scabies, okay, doesn't really cause a widespread chronic thing. No. So the answer is B.
Okay, so we can move to the third question, which reads, a patient with HIV presents with multiple painful group to vesicles on an erythematous base following a dermatomal pattern. What is the most likely diagnosis? Oh, this one is quite interesting. Okay, we're at 41%, just a few more votes. Okay, the 100% has been broken. Okay, I think we can stop the poll and share the results. Doc, any comments?
No, others are just voting for the sake of just voting. This one, even before we started, we talked about it, that dermatomal pattern, okay, painful, multiple grouped vesicles, when it matters base, the epizoster. So Kaposi sarcoma is not painful. We discussed that. Psoriasis may be itchy, but it's not painful. Okay. Yeah, but psoriasis doesn't have grouped vesicles. Impetigo, yes, they may be grouped vesicles, the bolus impetigo, but it's not painful and does not follow dermatomes. So correct answer is B, epizost.
Okay.
But we know most people, at least 93%, it's good.
Yeah. So I think basically the way the poll questions were answered compared to the earlier ones, there is some knowledge transfer that has happened. I think this is the last poll question. In terms of the chat, we only have one question that came from Isaac Tembo, who asks, can Septrin trigger the Steven Johnson syndrome?
Yes, so Septrin is a sulfur-containing drug. So Septrin can trigger SJS. So as you prescribe this medicine, it's very important that you find out whether these patients have got any drug reaction. Even from history taking, there is that part where past medical history, surgical history, past drug history, you also find out about allergies. So as you initiate these patients or as you put them on any drug, you may need to find out whether they have any non-drug allergies. But even if they tell you they don't know, when you start, you tell them that it's possible that you can react to this drug. If they feel anything unusual, they can. So SJS can be triggered by Septrin. Yeah, Septrin, Fancida, carbamazepine, all these they can trigger SJS.
Okay, thank you so much. At this moment, since we've gone 7 minutes beyond time, I'll give a chance anyone who has a burning question from the chat, something you would like to find out or ask. Okay, so there's a question where can we send pics of skin conditions we encounter via telemedicine?
That's it?
Dr. Malan, where can they send pictures of skin conditions which are encountered in case they need consultation? I think the number you shared at the end can be used, isn't it? Or the email?
The number can be used, or the organizers of this event, we can see how we can. Okay, I'll chat with the organizers so that we can have either a WhatsApp or where these things can be sent, or my number. It's fine still. Okay.
Okay. So I think Chatonda, you can facilitate that process so that we have access and we can send pictures for any consultative communication that might be needed.
Okay.
Okay.
So
I think all right, the number will be shared, I think, in the different platforms. Then the other thing is if you have access to iEcho, the the presentation is also shared there, and you can equally access the number on the same in the same presentation. But as guided, we'll see how we can make a platform where those can be shared and the feedback can be provided. At this moment, I'll take this time to say thank you to Dr. Malan for coming through as an expert presenter on this session and all the panel of experts that were invited. Also want to say thanks to the IT team, Chatonda, for facilitating the process. And we definitely want to say thank you to all the participants that have joined, and we were part of this meeting from start to this time at the end. I think with that, we'll call the meeting to an end. Thank you so much. Have a good day. Bye-bye.